Ladies and gentlemen, it is a real pleasure to be allowed to stand up here and introduce the speaker for today. Not only because I've read his book with great pleasure, and I'll go into that in a moment, but also because I have had what we call a sneak preview. This afternoon, knowing that Atul Gawande was in Amsterdam, I said, well, this is the one thing I can offer my students and my residents. Can't we get him to come for an hour to the Academic Medical Center and speak to the counterpart of what he is used to around him in Boston, in the Amsterdam arena? And we had a large audience in the lecture hall, and I know that they were very much looking forward to it and very, very much enjoyed your talk this afternoon. Partly because I think they will have recognized so much in your book about what happens to them daily, and probably, as it happens in your book, in your country, people don't always speak out these things out loud in the open. And having somebody who writes about it and then is willing to come and discuss it must have helped them to discuss these things among themselves. Now, you who have not had a sneak preview may wonder what he writes about. Atul Gawande is a writer and a surgeon. A very unusual combination, I can tell you. And I didn't quite understand it until I read a little bit more about his curriculum vitae in the back, and saw to my delight that he also had a degree in philosophy and economics, was a policy advisor, and had a degree in public health, which is my field in medicine. I thought, now I understand how you can be a writer and look at medicine not only from the inside, but be able to get an overview from far enough above to see a network of people, a system with systematic elements that may determine some of the outcomes. So it's not unusual to have a writer and a surgeon if he has an MPH. And when you look at his book, you see the two strands kind of woven together. The young writer who starts with internet columns, and he explained this afternoon, nobody read them. Very nice to start off with. Then goes on to write essays in the New Yorker, and finally takes that final step to write a book. And he's very good in the back of his book to write about how it feels to move up that ladder. And that's very similar with the way, as a medical student, you slowly move up the ladder in which you're given responsibilities and you have constant feedback about what you do. Now, the book itself talks about something, as I said earlier, that we don't often bring out into the open. The fact that in medicine, it being a human science, sometimes things go wrong. Not because doctors are bad doctors, but because complications can occur. And that's no different than from any other field that you may be looking at. But in medicine, it always concerns human lives. And therefore, we feel much more strongly about how we handle these mistakes that can happen, these complications that can occur. And he writes beautifully about the way the system has organized itself to be open about mistakes that individuals can make, to help look and analyze complications and try and see whether we can learn from them to prevent them the next time. And nevertheless, at the same time, describes a system that is fallible because the systematic error that is in there is much more difficult to address by autonomous professionals, the doctors are, than they are in any other industry. I think it is that tension between being so good about using complications as a way to learn in the future and having a system that has such difficulty adjusting itself to prevent error that makes the book very, very interesting for somebody who works within the health field. This afternoon, the audience was much more enthralled by what you write in your book about learning medicine, how difficult it is, how scary it is at times, and how there is no other way to learn it than with real human patients. Now, if I go on, I will tell the audience much too much, and I won't leave you anything to read about in your book, and I think your words are much nicer than mine to tell them the story that you've told in this beautiful book. And I'd like to ask you to come up here and tell your own story.
Thank you so much, Dr. Gunning, and thank you for the invitation from the John Adams Institute, for coming here and having a chance to talk a little bit about my book. But also, for me, this is a very significant place because this was the very first non-English speaking country that took an interest in my book. There was a time when the book first came out when we thought it was going to be a small interest with perhaps, I hope, some literary interest. But I did not expect it would become a bestseller in the United States and did not expect so many other countries to take an interest. And there's a great deal in the great part of the world that it turns out it will be coming out in the coming year. But within a month or two of sending the manuscript around to other parts of the world, we heard back from Arbiter's Press here, who had taken an interest in the topics and wanted to bring it here. And as a result, this is the first non-English speaking country in which it is coming out. And I'm grateful to everybody here in Holland for taking that kind of an interest in topics that can seem very narrow, surgery, after all. But they saw in it what I'd very much hoped it would be, which is a book that tried to reach from the particular experience of surgery to how it is our lives unfold nowadays in the modern world where you are so dependent on medicine, and how it is that decisions are made when you are so dependent, when we're all so dependent on medicine for the success of our lives. About 4 years ago, I found myself in the odd and also wonderful position of getting to write occasional essays about medicine and science for the American literary magazine, the New Yorker magazine. And 2 years into it, I was approached by a publisher with the very flattering idea of putting my ideas about medicine together for a book. I said, of course, well, I'd love to. I didn't know yet what my ideas were. I knew there were themes that I had been exploring for some time, ways of talking about what it was that were the puzzles in medicine and the confusions in medicine, the kinds of things that I couldn't find answered in my textbooks. And gradually, I took essays that had started in the New Yorker, added more essays, and found that there was, in some ways, some larger sense about how imperfection occurs in medicine that seemed important to try to trace. I'm a surgical resident, still, therefore, a young doctor, someone nearing the end of my 8 years of training in surgery. And this book arises out of the intensity of that experience. Medicine is a kind of weird business, and writing became my way of trying to think through what it is that we do. It seems that we've arrived at a new, important, but also, I think, confusing juncture in medicine. On the one hand, to all of us, medicine has become extraordinarily powerful and successful, extending our lives, whether we have heart disease, many types of cancer, making our lives better even in the face of such illnesses as depression. On the other hand, strangely, as powerful and successful as medicine has become, doctors are less trusted than they once were. The notion that doctors are gods has long faded. People are now expected to take medical decisions into their own hands, make decisions about the course of your lives for yourselves, and not necessarily do what doctors tell you to do. I don't think anyone has prepared anybody for this, not doctors or patients. No one has really shown people how medicine really works, what decisions really matter, how they are made, how much uncertainty there is, and then how that uncertainty is dealt with, both by patients who are trying to make these decisions and by doctors. And so that's what I tried to show in this book, how it is that things go right, how things go wrong, and then why. The thing that I come back to about medicine is what startled me in the very beginning when I started out. I'm the son of two doctors. My mother's a pediatrician. My father is a urologist who had originally started as a general surgeon. And they met in New York, where they both were in training themselves. I was born in New York and then grew up most of my life in Athens, Ohio, which is a small town near the West Virginia border and the Ohio River. It's about 10,000 people with a university there of almost equal size. And I grew up in the hands then of small town doctors. I'm now finishing my training at Harvard Medical School in a hospital that employs 10,000 people, which is about the size of my town. And the distance between that small town experience in medicine and that larger experience in medicine turns out to be not very different. I think the thing that you find in all of these places is that medicine is fundamentally a human endeavor, which surprised me. When we think about medicine today, what we tend to think about is all of the knowledge, the powerful technologies, and the stunning abilities that you read about in the newspapers and hear about on the television with whatever breakthroughs or gizmos there might be. But what you find when you actually get in close is a much messier, more fragile reality of an individual doctor and an individual patient trying to sort through all of that. If you have a terrible belly pain, and then you want some help with that. And it's the amazing know-how and the medicine and the technologies that you want. But what do you get? Instead, what you get is just a doctor, someone with bad hair and a weak chin and annoying little jokes and some things that they know and some things that they don't. We make decisions, even choose to do major operations, despite at many times unclear evidence about what the absolute right thing to do is, or even necessarily even close to what the right thing to do is. It's not surprising that these situations are a struggle for doctors and patients, and it's not surprising that the results can be less than we want or we expect them to be. In the end, we come to medicine to try to think of it as an orderly field of knowledge and procedure. But it's not. Some of that can be helped, and I think some of it can't. And that's what I end up trying to trace out in the book, is what it is that can be better and what it is that we have to be flat out honest about, not ever having a chance of achieving perfection. There are, I think, 3 reasons that things in medicine don't always turn out the way you expect them to or the way that we think they are supposed to. 3 layers in a distance between theory and practice. And they make up the 3 sections of my book. I think, so the first section of the book is what describes and outlines what may be the most upsetting cause for imperfection in medicine, and that is our fallibility. So in the chapters in this section, I consider everything from the dilemmas of the learning curve and the moral difficulty of the fact that we need to practice upon people, to mistakes and how they occur, to and in that chapter I try to talk about a topic that even was hard for me, which is the mistakes that I've made along the way, mistakes that have at times brought harm to people. And then also considering a problem like how a profession like ours polices itself for troubled individuals or people at a difficult point in their careers who may not be safe to practice. I think these are all worries that patients, that almost anybody has along the way. But also, these are all things I don't think we've explained or even necessarily understood particularly well. A core element and a hard to understand element is that every doctor I know makes terrible mistakes in the course of a year. Most mistakes occur not in the hands of bad doctors, but in fact in the hands of good doctors. Thinking through what that means for all of us, then, is part of what I set out to do in that first section. The second reason behind the imperfection of medicine is how much mystery there still is in the human condition. How much of medical science still remains terra incognita. These are not obscure and rare areas For sure, we don't know exactly how the Ebola virus works. But we also don't know very much about, say, how pain works. In one chapter, I consider the troubles of an architect with one of the most common problems to present themselves to doctors, chronic back pain. He was an architect who helped build one of our major medical schools. He a tremendously active and busy man who one day on one of his construction projects fell into a pit, broke his shoulder, which was mended, but came out of the whole thing with a kind of chronic aching back pain that over the course of a few years extended to leaving him almost incapacitated, unable to do his work. He would attend a client's meeting and have such spasms of pain that one time he threw up right in front of his own client. He ended up having to lose his practice. He saw doctor after doctor. They did x-rays, they did MRIs, and as is often the case with chronic back pains, found nothing wrong with his back. He was one of those patients who makes many of us want to run away when they turn up in clinic with their chronic complaints and the many doctors they've seen and nothing we've been able to figure out. In another chapter, I examine the story of a woman with intractable nausea and vomiting that wouldn't go away, but no doctor could find an explanation or treat it. And there are more chapters considering what may seem a kind of weird range of topics, but they come back to what it is that both doctors and patients do when good answers cannot be found. There's a chapter about a 450-pound man who underwent radical gastric bypass surgery to shrink his stomach and bypass some of the absorptive capacity of his intestine so that he might lose weight. A very popular and growing operation, I know, here as well as around the world, and yet one that is a very strange and puzzling operation. The only operation I've ever seen whose goal is to control the will rather than to fix any kind of disease in a direct way. Another case was a newscaster, a television presenter, who had such severe and unmanageable blushing that eventually she lost her job and came to a surgeon to ask the surgeon to take away her ability to blush. And he did. The holes in science and the errors that are possible are two sources of our imperfection. The third, though, is, I think, the critical and inherent element in medicine, and that is uncertainty. Even if we eliminated mistakes, and even if the science of human afflictions were to become completely understood, there would still be inevitable uncertainty in what we do that comes from the sense in which all that we know about people are what we know about groups of people. And yet you have an individual in front of you, and how much does all that statistical knowledge about the group really help you decide the absolute right thing to do for this one new person standing in front of you? It's this uncertainty that makes perfection unachievable. And also, there is the finding that on the one hand, throughout the world, autopsies are declining. Used to be, in the Western world, the majority of deaths were autopsy. There was something that doctors sought to learn from autopsies, and what they found, looking at studies from the 1930s and 40s, for example, was that 40% of autopsies turned up a misdiagnosis. About a third of those misdiagnoses could be something that you could do something about. That was the 1930s. They repeated those studies in subsequent decades, most recently only 2 or 3 years ago. And the startling thing is that although at this point we have almost given up on autopsies as an institution, when you study autopsies in places where they're still done widely, it's still 40% that turn up a misdiagnosis. Despite our technology, despite all of our imaging, they're still more puzzling than you might expect in medicine. I consider the case of a mother accused of murdering her 8 children, although physicians had first thought that they were victims of sudden infant death syndrome. And then the question was, who was going to be right, the prosecutors or the physicians? And on what basis could the physicians even really say they were right? Towards the end, what I try to think through, though, are several cases where you begin to see how doctors and patients might together sort out how to make decisions in the face of uncertainty. There are cases where you have people struggling over questions of how do you ask a doctor for a second opinion, tell them that you may not want to go with their decision, or others who decide to simply accept what's before them. And they go through it. They make these decisions, sometimes well and sometimes not so well. We've had, in a sense, a century now of writing about the art of doctoring. But what it turns out is that there is really an art to being a patient. There are times when you have to push hard, you have to ask questions, you have to even seek second opinions, maybe even anger your own doctor. And yet, on the other hand, there are other times when you have to be willing to put yourself in somebody else's hands, to trust in somebody who is, after all, an ordinary human being, understanding that they're not gods, understanding, though, that they are ordinary human beings who are somehow capable of doing extraordinary things, taking a population of people and giving them a chance not to live to their mid-60s, like human beings did only 3 decades ago, but live to your mid-80s, with 5 out of 6 who are still able to live independently at home, under their own 2 wheels, with intact minds, intact lives. And that very struggle in defining our lives and defining the course of our lives and how medicine should fit into it and how to trust others, how to make a decision about all of these things is the art of being a patient. It's sort of the art of living. And it is, I think, the final theme that we all come to. In reading from the book, though, what I wanted to do was try to pick up one of the threads running through the book. And the thread is a kind of puzzle. It's the puzzle of how medicine could be as deeply uncertain as it is at times, and is plagued by human fallibilities, but at the same time, so successful. So I'm going to start by reading just from the very beginning. To sort of set the scene. I was once on trauma duty when a young man, about 20 years old, was rolled in, shot in the buttock. His pulse, blood pressure, and breathing were all normal. A clinical assistant cut the clothes off of him with heavy shears, and I looked him over from head to toe, trying to be systematic but quick about it. I found the entrance wound in his right buttock cheek, a neat red half-inch hole. I could find no exit wound. No other injuries were evident. He was alert and scared, more of us than the bullet. "I'm fine," he insisted, "I'm fine." But on the rectal exam, my gloved finger came back coated with fresh blood, and when I threaded a catheter into him, bright red flowed from his bladder too. The conclusion was obvious. The blood meant that the bullet had gone inside him, through both his rectum and his bladder, and that's what I told him. Major blood vessels, his kidney, other sections of bowel may have been hit as well. He needed surgery, I said, and we had to go now. He saw the look in my eyes, the nurses already packing him up to move, and he nodded, almost involuntarily, putting himself in our hands. Then the gurney wheels were whizzing, IV bags swinging, people holding doors open for us to pass through. In the operating room, the anesthesiologist put him under. We made a fast, deep slash down the middle of his abdomen from his rib cage to his pubis. We grabbed retractors and pulled him open. And what we found inside was nothing. No blood, no hole in the bladder, no hole in the rectum, no bullet. We peeked under the drapes at the urine coming out of the catheter. It was normal now, clear yellow. It didn't have even a tinge of blood anymore. Excuse me. We had an x-ray machine brought into the room and got an x-ray of his pelvis. Got x-rays of his pelvis, his abdomen, and also his chest. They showed no bullet anywhere. All of this was odd, to say the least. After almost an hour more of fruitless searching, however, there seemed nothing to do but sew him up. A couple days later, we got yet another abdominal x-ray. This one revealed a bullet lodged inside the right upper quadrant of his abdomen. We had no explanation for any of this. How a half-inch long lead bullet had gotten from his buttock to his upper belly without injuring anything. Why it hadn't appeared on the previous x-rays, or where the blood we had seen had come from. Having already done more harm than the bullet had, however, we finally left it and the young man alone. We kept him in the hospital for a week. Except for our gash, he turned out fine. Medicine is, I have found, a strange and in many ways disturbing business. The stakes are high, the liberties taken tremendous. We drug people, put needles and tubes into them, manipulate their chemistry, biology, and physics, lay them unconscious, and open their bodies up to the world. We do so out of an abiding confidence in our know-how as a profession. What you find when you get in close, however, close enough to see the furrowed brows, the doubts and missteps, the failures and the successes, is how messy, uncertain, and also surprising medicine turns out to be. The puzzle of it is that there is almost, you almost don't see the, well, thank you. You almost don't see the uncertainty unfolding. But if you listen closely, you actually will hear it. Excuse me. I'm getting to be like Bill Clinton these days. Maybe. She comes well equipped. Thank you.
It's uncertain, I can tell you, whether it's going to help.
Seeing patients with one of the surgery professors in his clinic one afternoon, I was struck by how often he had to answer his patients' questions, "I do not know." These are 4 little words a doctor tends to be reluctant to utter. We're supposed to have the answers. We want to have the answers. But there was not a single person he did not end up saying those 4 little words to that day. There was a patient who had come in 2 weeks after an abdominal hernia repair. "What's this pain I feel next to the wound?" There was the patient 1 month after a gastric bypass operation. "Why haven't I lost weight yet?" There was a patient with a large pancreatic cancer. "Can you get it out?" And to all, the attending gave the same reply: "I do not know." A doctor still must have a plan, though. So to the hernia patient, he said, "Come back in a week and let's see how the pain is doing." To the gastric bypass patient, "It'll be all right," and asked her to come back in a month. To the cancer patient, "We can try and get it out." And although another surgeon thought he shouldn't, given the tumor's appearance on a scan, operation would be futile and risky, the colleague said, and he himself thought the odds of success were slim at best. He and the patient, who was only in her 40s, with still young children at home, decided to go ahead. The core predicament of medicine, the thing that makes being a patient so wrenching, being a doctor so difficult, and being part of a society that pays the bills they run up so vexing, is uncertainty. With all that we know nowadays about people and diseases and how to diagnose and treat them, it can be hard to see this. hard to grasp how deeply the uncertainty runs. As a doctor, you come to find, however, that the struggle in caring for people is more often with what you do not know than what you do. Medicine's ground state is uncertainty, and wisdom for both patients and doctors is defined by how one copes with it. There is the trick of medicine, is that we have made a kind of science of managing uncertainty. Experience turns out to matter greatly, for one thing. And also, just as important, simply being systematic about what we do. And when I was trying to think of an emblematic, almost a symbol of what this meant, I remembered a place that we often hear about in surgery. They publish very frequently the results of a little place up in Toronto, and decided to go there and visit. So let me read a little bit from this section about this place called the Shouldice Hospital. Consider a relatively simple surgical procedure, a hernia repair, which I learned to do as a first-year surgical resident. A hernia is a weakening of the abdominal wall, usually in the groin, that allows the abdomen's contents to bulge through. In most hospitals, fixing it, pushing the bulge back in, and repairing the abdominal wall takes about 90 minutes and might cost upwards of $4,000 US. In anywhere from 10 to 15% of the cases, the operation, however, eventually fails and the hernia returns. There is, nonetheless, a small medical center outside Toronto known as the Shouldice Hospital, where none of these statistics apply. At Shouldice, hernia operations often take from 30 to 45 minutes. Their recurrence rate is an astonishing 1%, and the cost of an operation is about half of what it is elsewhere. There's probably no better place in the world to get a simple hernia repaired. So what's the secret of that clinic's success? The short answer is that the dozen surgeons at Shouldice's hospital do hernia operations and nothing else. Each surgeon repairs between 600 and 800 hernias a year, more than most general surgeons do in a lifetime. In this particular field, Shouldice's staff is better trained and has more experience than anybody else. But there's another way to formulate the reason for its success, which is that all the repetition changes the way they think. It makes them think like machines. One chilly Monday morning, I put on a green cotton scrub top and pants, a disposable mask, and a paper cap, and wandered among cases in the Shouldice Hospital's 5 operating rooms. To describe one case is to describe them all. I watched 3 surgeons operate on 6 patients, and none deviated in even a step from their standard protocol. In a tiled box-like operating room, I peered over the shoulder of Richard Sang, a 51-year-old surgeon with a dry wit and youthful appearance. Though we chatted during the entire operation, Dr. Sang performed each step without pause, almost absently, and the nurse handing over exactly the right instruments. Instructions between them were completely unnecessary. The patient, a pleasant, surprisingly composed man of about 35, who occasionally piped up from under the drapes to ask how things were going, lay on the table with his lower abdomen exposed and painted yellow with a bactericidal iodine solution. A plum-sized bulge was visible to the left side of the hard bone of his pubis. Dr. Sang injected the skin with a local anesthetic in a diagonal line from the top of the man's left hip to the pubis along the crease of the groin. With a number 10 blade, he made a 4-inch slash along this line in a single downstroke, revealing yellow, glistening fat below. The assistant laid a cloth along each side of the wound to absorb the mild bleeding and pulled it open. Sang swiftly cut down through the outer muscle layer of the abdominal wall, exposing the spermatic cord, a 1/2-inch cable of blood and spermatic vessels. The patient's bulge, we could now see, came through a weakness in the muscle wall beneath the cord, which is a common sight. Sang slowed down for a moment, checking meticulously for another hernia, along the area where the cord comes through the inner abdominal wall. Sure enough, he found a small second hernia there, one that if it had been missed, would almost certainly have caused a recurrence. He then sliced open the remaining muscle layers beneath the cord so that the abdominal wall was completely open and pushed the bulging abdominal contents back inside. If you have a tear in a couch cushion with stuffing coming through it, you can put a patch on the cushion, or you can sew the edges back together. At my hospital, we usually push the hernia back in and place a piece of sturdy plastic-like mesh on top and sew it to the surrounding tissue. It provides a reliable reinforcement, and the technique is pretty easy to perform. But Sang, like the other Schuldeis surgeons I asked, scoffed at the idea. They viewed the mesh as a hazard for infection, since it's a foreign body, expensive, since the mesh can cost hundreds of dollars, and unnecessary, since they get enviable results without it. As Sang and I talked about such alternatives, he sewed the wall back together in 3 separate muscle layers using fine wire, of all things, making sure that the edge of each layer overlapped like a double-breasted suit. After Sang closed the patient's skin with small clips and removed the drapes, the patient swung his legs over the edge of the table, stood up, and walked out of the room. The procedure had taken just half an hour. Many surgeons elsewhere use Schuldeis's distinctive repair method, but get very ordinary rates of recurrence. It's not the technique that makes Schuldeis great. The doctors at Schuldeis deliver hernia repairs the way Intel makes chips. They like to call themselves a focused factory. Even the hospital building is specially designed for hernia patients. Their rooms have no phones or televisions, and their meals are served in a downstairs dining hall. As a result, the patients have no choice but to get up and walk around, thereby preventing problems associated with inactivity, such as pneumonia or blood clots in their legs. After Sang left the patient with a nurse, he found the next patient and walked him straight back into the same operating room. Hardly 3 minutes had passed, but the room was already clean. Fresh sheets and new instruments were already laid out. And so the next case began. I asked Bernd Schuldeis, the son of the clinic's founder and a hernia surgeon himself, whether he ever got bored doing hernias all day long. I know I would have. No, he said in a Spock-like voice. Perfection is the excitement. Paradoxically, this kind of super specialization raises the question of whether the best medical care requires fully trained doctors even. None of the 3 surgeons I watched operate at the Schuldeis Hospital would have been allowed to conduct their own procedures in a typical American or British or, I suspect, Dutch hospital, for none had completed training in general surgery. Sang was a former family physician. Bernd Schuldeis had come straight from medical school with no training in any particular field. And the surgeon-in-chief was an obstetrician. Yet after apprenticing for about a year or so, they were the best hernia surgeons in the world. If you're going to do nothing but fix hernias or perform colonoscopies, do you really need, you begin to wonder, the complete training in order to excel? It even raises the question of, depending on the area of specialization in which you work, but whether you even need to be human. And that's the question I go on to explore in that chapter. So experience matters. Being systematic, almost formulaic, thinking very concretely and practically matters greatly. It makes you begin to wonder whether the direction in medicine is that we can eliminate a lot of the vagueness and the uncertainty. And what you find out is that there's still much left over where you can't. We probably do not go far enough, not probably, I know we don't go far enough by all the evidence in being as systematic about the care we provide and the decisions we make, or relying on computers as much as we could. But at the same time, the role we give to intuition, although it's probably too large, will never quite disappear. And so I want to finish, before we turn to questions and discussion, with a reading from a section which tries to grapple with why that might be. In a 1976 essay, the philosophers Samuel Gorovitz and Alistair McIntyre explored the nature of fallibility. Why, would a meteorologist say, failed to correctly predict where a hurricane was going to make landfall? They saw three possible reasons. One was ignorance. Perhaps science affords only a limited understanding of how hurricanes behave. A second reason was ineptitude. The knowledge is available, but the weatherman fails to apply it correctly. Both of these are surmountable sources of error. We believe that science will overcome ignorance and that training and technology will overcome ineptitude. The third possible cause of error, the philosophers posited, however, was an insurmountable kind, one they termed necessary fallibility. There may be some kinds of knowledge that science and technology will never deliver, Gorovitz and McIntyre argued. When we ask science to move beyond explaining how things, say hurricanes, generally behave, to predicting exactly how a particular thing, say Thursday's storm off the coast, will behave, we may be asking it to do more than it can. No hurricane is quite like any other hurricane, although all hurricanes follow predictable laws of behavior. Each one is continuously shaped by myriad uncontrollable accidental factors in the environment. But when it comes to inferring exactly what is going on in a particular person, well, are people more like ice cubes, or are they more like hurricanes? Right now, at about midnight, I'm seeing a patient in the emergency room. Obviously not right now. And I want to say that she is an ice cube. That is, I believe I can understand what's going on with her, that I can discern all her relevant properties. I believe I can help her. Charlotte Duveen, as we will call her, is 49 years old, and for 2 days she has had an abdominal pain. I begin observing her from the moment I walk through the curtains into her room. She is sitting cross-legged in the chair next to her stretcher and greets me with a cheerful, tobacco-beaten voice. She does not look sick. No clutching the belly. No gasping for words. Her color is good, neither flushed nor pale. Her shoulder-length brown hair has been brushed, her red lipstick neatly applied. She tells me the pain started out crampy like a gas pain, but then during the course of the day it became sharp and focused, and as she says this, she points to a spot in the lower right part of her abdomen. She has developed diarrhea. She constantly feels as if she has to urinate. She doesn't have a fever. She is not nauseated. Actually, she is hungry. She tells me that she ate a hot dog at Fenway Park 2 days ago and visited the exotic birds at the zoo a few days before that, and she asks if either might have anything to do with this. She has 2 grown children. Her last period was 3 months ago. She smokes half a pack a day. She used heroin. Once used to use heroin long ago, but says she's clean now. She once had hepatitis. She has never had surgery. I feel her abdomen. It could be anything, I think. Food poisoning, a virus, appendicitis, a urinary tract infection, an ovarian cyst, a pregnancy. Abdomen is soft, without distension, and there's an area of particular tenderness in the lower right quadrant. When I press there, I feel her muscles harden reflexively beneath my fingers. On the pelvic exam, her ovaries feel normal. I order some lab tests. Her white blood cell count comes back elevated. Her urinalysis is normal. A pregnancy test is negative. I order an abdominal CT scan. I'm sure I can figure out what's wrong with her. But if you think about it, that's a curious state. I have never seen this woman before in my life, and yet I presume that she is like the others I've examined. Is that true? None of my other patients, admittedly, were 49-year-old women who had had hepatitis and a drug habit, had recently been to the zoo and eaten a Fenway Frank, and had come in with 2 days of mild lower right quadrant pain. Yet, I still believe. Every day, we take people to surgery and open their abdomens, and broadly speaking, we know what we will find. Not eels, or tiny chattering machines, or a pool of blue liquid, but coils of bowel, a liver to one side, a stomach to the other, a bladder down below. There are, of course, differences. an adhesion in one patient, an infection in another. But we have cataloged and sorted them by the thousands, making a statistical profile of all of mankind. Anybody want to guess what they think this patient might have? Food poisoning. So I was leaning towards appendicitis. Why? The pain was in the right place, it seemed. The timing of her symptoms, her exam, and her white blood cell count all fit with what I had seen before. She was hungry, however. She was walking around. She did not look sick, and that seemed unusual. I go to the radiology reading room and stand in the dark, looking over the radiologist's shoulder at the images of Devine's abdomen flashing up on the monitor. He points to the appendix, worm-like, thick, surrounded by gray, streaky fat. "It's appendicitis," he says confidently. I call the attending surgeon on duty and tell him what we've found. "Book the OR," he says. So we're going to do an appendectomy. This one is as sure as we get. Yet I've worked on similar cases in which we opened up the patient and found a normal appendix, food poisoning. Surgery is a kind of autopsy in itself, and autopsy literally means to see for oneself. And despite our knowledge and technology, when we look, we're often unprepared for what we find. Sometimes it turns out that we've missed a clue along the way, made a genuine mistake. Other times we turn out wrong despite doing everything right. From what I've learned, looking inside people, I've decided human beings are somewhere between a hurricane and an ice cube. In some respects, permanently mysterious, but in others, with enough science and careful probing, entirely scrutable. It would be as foolish to think we have reached the limits of human knowledge as it is to think we could ever know everything. There is still room enough to get better, to learn from knowing when our simple certainties are wrong. I'm going to stop there. And thank you for these. Okay.
Should we do that? Yeah.
Well, Atul, it's marvelous to get a chance to talk a bit more about your book. Although we already had a chance to talk a little bit about your family, your 3 children are part of the book. They come as patients all through the book. And I couldn't quite believe that it was true, but you convinced me in the end that all the stories are in there. But they're indicative, I think, of some of the dilemmas that you put in your book. A book like this comes from a long tradition. There's been a tradition of young doctors writing about the experience of growing up to become a doctor and sharing some of the uncertainties you have as a resident, as an intern, learning how to do medicine and telling some of the hilarious things that can happen to you, the anecdotes. And I think many generations grew up in it, and I wouldn't be surprised if the next generation will talk about your book in that same way in the future. Your book also fits in the tradition of medical mysteries. I took epidemiology, having read Boucher's Medical Mysteries, and I loved them. But they also always gave you the solution. Your stories sometimes leave you wondering why we haven't found the solution to some of the mysteries. And I think what makes your book very special is that you use the anecdotes, both the anecdotes telling about what it's like to try to become a doctor, and anecdotes telling you about medical mysteries, to pull it up one more layer towards the abstract, and getting out some of the really big dilemmas that we have in practicing medicine and in teaching medicine as we do at the AMC. And I think I'd like to talk to you about that a little bit more. This afternoon you read some passages in your book that tell about doing things for the first time and how scary it is to do that, and how when all of you think about where you would want to go for an operation, you think that when you go to an academic hospital, you will get the absolute top expert to operate you. This one professor who's known around the world for his orthopedic surgery or his gastroenterological surgery. Well, in reality, you may well end up getting a resident operating for the very first time. That means you're somewhere on the learning curve of a young doctor who in the end may turn out to be absolutely brilliant, but he isn't there yet. And we talked this afternoon about the fact that there is no way around the need to do that. You can only practice on human beings, but there is no way we can ask informed consent to do that, because nobody would say yes if they were given the choice. Now, we go very far about getting informed consent for research, and we don't allow people to even think about touching patients as a part of a research project unless the Medical Ethical Committee has given the approval, and most of all has looked at the informed consent form and agreed to let patients take that risk. Can you think of any way that we might get out of that dilemma of not being able to tell patients the fact that being part of a teaching experience may give them some risks, although we try to mitigate them as much as we can in the system, but that there's no other way for young doctors to learn?
I've thought about this, and what I end up having to come back to is what I would do as a patient. And my main experience with struggling with these questions has been with our eldest son, Walker, who is now 7 years old, but when he was 12 days of age, went suddenly into congestive heart failure for reasons that we couldn't understand. He turned out to have a portion of the arch of his aorta missing, needed to go to surgery and have it repaired, spent some time in an intensive care unit, was revived and brought through it, and after 2.5 weeks was actually sent home from the hospital. And on the way out the door almost, one of the junior trainees brought to me his card and said, well then, why don't you have Walker come see us next Tuesday, come see me next Tuesday. And I knew this was exactly the way that the trainee got his patients. He offered the card at the end as you're heading out the door. But I also knew the system very well. And I said, no, thank you. I'd like to see the associate chief of cardiology, who happens to be a published expert in problems like my son's. And the hard question and the hypocrisy to me was that I could get that choice, that I knew enough about how to work the system to get the best choice possible, and that often that's exactly what happens when a doctor comes in, is that we think very hard about how much training to do when the chief of surgery's mother comes in needing something done. And so the puzzle is, well, let me put it this way. I spoke to, in the course of telling that story, I spoke to a health policy expert and asked him what he thought we should be doing. And he thought what we should be doing was telling people like me that there is going to be an opportunity for learning from your son. And would you want to have the best person in the hospital seeing her, or have one of the new trainees? And he said that, sometimes people are going to make that choice, not always, but many times, and a lot more than I thought, in favor of the teaching. I did a very sneaky thing. I saw the picture of his son on his desk, and I asked him whether he let the resident deliver his child. And he said no. He wouldn't even let the residents in the room. That's the dilemma. We want perfection without practice. And yet, in order to have a future generation of medicine, we have to have a way for the practice to be able to occur. Given the choice, those of us who know anything about it, even the slightest bit, will wriggle out. And then it's the truck driver's kids and the poor or the destitute that we end up practicing upon. It's one of the most uncomfortable morally positions that you find yourself in as a trainee, and I don't think that that's the way it should be. So then how do we resolve that? And I think the only way is by almost by taking the choice away. When I look back on my son's experience in the hospital, I realized that a resident did scrub in to his operation and put in some of the stitches in his heart. It was a first-year trainee who put him on the breathing machine, a first-year fellow who put his central line in, a needle into his chest, threading a catheter into his heart. All things that if somebody had come to me and asked if I would rather have somebody else do it or not, I would have said absolutely. But it was acceptable to me because I wasn't given the choice. And it put the responsibility on the hospital to make that as safe as possible, make it go as well as possible. And every doctor knows that when it comes to that these kinds of things are things that when they come in are going to be the routine way that things are done and the way that things are done to them. And it's sort of like the jet pilot who is going to check twice about that plane before he gets on board. When everybody's included, the people who are educated and in the know see to it that the system works as well as possible. But I don't see a way around the dilemma that given informed choice, most people would not allow for any teaching at all.
I don't see any way out. I think no choice is the best way. And then I come to my second part. What you described very nicely is that you try to set up a system whereby there are so many safeguards that even if something doesn't go absolutely right because somebody is doing it for the first time, there's always a backup to make sure that in the end the patient doesn't really suffer. We can't always.
You hope.
We can't always avoid it, but you try to limit that to the extent that you can. And that brings me to the piece you read about the hernias. I mean, I could not imagine doing hernias all my life. It would be the most boring thing. And yes, perfection you can aim for, but once you've achieved it, how long is it fun to maintain it? It's an enormous price to pay to achieve that kind of perfection in doing one small little bit. The other extreme is that we bring up doctors to be professionals with an enormous amount of professional autonomy and professional ethics in which they try to achieve perfection not in one area but in a broad area of diagnostics and therapeutic interventions, those that are not done exactly according to the book but that are maybe more difficult because they're slightly different or because you're not quite certain what you're going to find. Now, in training doctors, do you think that they both have to go the same route, or could you have doctors to do the main diagnostics, and once you know which therapy there is, there can be a medical technician to do it who does nothing else but hernias?
Well, you have, in a sense, you have two tensions. One is that there's so much knowledge, so much technology, so many directions in which medicine's going that medical training ends up having to be longer and longer in order to be able to have them be both broad and deep. Mm-hmm. When it comes to diagnosis, it is still a relatively primitive world of medicine. We have x-rays and scans and a few diagnostic tests, but the minute you bring in, as we will in the next decade or so, genetic variability, the genetic individuality of people, and ways that you can correlate how your own genes change the very profile of problems that you might have. I think even diagnostics will become ever finely divided and ever finely specialized. It is still, you still need a group of people who can take the person who comes in with what seems like a simple problem. They've got a pain somewhere. And that pain could turn out to be anything, like that woman that I saw. And you need someone who can sort out, okay, well, at least is this serious? Is this not serious? What kind of people do I need to bring here as part of the team? You have to have almost someone who becomes particularly good at triage, at being the guiding gatekeeper into the whole complex organism of medicine. But even they, in a sense, have become specialists. The primary care doctor, in all of their breadth, become specialized at being able to mainly recognize the situations in which one team is needed versus another, and it's different sets of approaches. And that
continual super specialization and ever fine division, I think will only proceed onward.
If I take that same paradox about this, the systematic of the improvement of the system to try and minimize risks or complications, and professional autonomy on the other side, and we then use them as ways to try to redress or to learn from complications. You describe very nicely the mortality and morbidity meetings that the surgical department has within your hospital, and they're very recognizable as the same weekly discussions that our surgical department has about complications that have occurred, whereby you try to at least discuss them so that not only the people who were present at that particular operation can learn from it, but where together the best brains available in the department try to learn and get something out of it so that the next time you can prevent that. That's a very, how would I say it, almost traditional way of learning from the mistakes you make, and it's very much ingrained in medicine, but it's always behind closed doors. There is the safety of knowing that you can admit to having done something that turned out to go wrong, and to be open about it so that others can learn from it. Now, there's a lot of call, and I know it happened in the States as well, to err is human. Was a report telling about how many complications occurred within the medical system and how one should be open about reporting them so that patients would have a choice where to go, but also so that the public would know how many mistakes were made. Now, if you take these discussions and put them out in the open press, can we still learn from them? Will people still be willing to be open about the mistakes they have made? And will it help us to get a better system than if we try to perfect the system of the internal learning curve that you have within departments?
It gets to the core psychology of the relationship between a person and somebody you're going to trust to take care, put your life into their hands. We still, at some level, have a fantasy about the people we ask to take care of us. And that is that, okay, fine, everybody is human and has imperfections, but this one is perfect. He's the best. And the difficulty is that there's polling to show this, that against all of our rational will, when you tell somebody that this person has made X number of errors during the past 6 months, that some of these errors have resulted in death and so on, it is hard to hold back the desire to say, my God, that guy's license should be taken away. The first impulse we have upon hearing that your loved one whose operation did not go very well and is ending up in the intensive care unit on a breathing machine from an infection that might have been prevented because people hadn't washed their hands perhaps, or because an antibiotic was missed and not given, is to get angry, to ask how can that be possible and be allowed to occur. And I think that's where some of the nervousness about the book comes from, and what I was nervous about coming about is whether you can create a language that allows you to get past that, allows you to then go on to say, okay, here is how these kinds of errors happen, here is how things can be improved, how things can change, and in the meantime, my own family can be taken care of. And my answer to that is I think that the answer can be yes. We are very afraid of talking to patients about the reality of medicine because we think that mostly we will just get the anger. But beyond the anger, people do move on. And the puzzle about medicine is that it is ordinary people. And ordinary people who are not gods, and yet people whom you can trust because you're far better off trusting in them than not. And so the reason is not because you think they're perfect, but because your life will go better putting yourself to some extent in other people's hands. which is very hard for all of us to do. The sense in which we have closed ourselves off, not talked about these errors, has made it so that there are both fear and inappropriate expectations that play an enormous role in what goes through people's mind when they're in the hospital or in a doctor's office. They and we maintain a kind of fiction that everything is going to go just fine. And you need that reassurance, but by admitting that it's not 100% of the time, but 97% of the time that it goes well, and that there's that 3% chance and the risk that you have to think about, it's a little unsettling, but enormously informative. And then when you really show people how it is that medical decisions unfold, the best way I can explain it is just talk about a patient I had who had read the first chapter of the book, which talks about the first time having to put a line into people, and a central line, being taught about it, and then how I teach other people to do it now. And I went to put a central line in a person who then said, "Oh yeah, I read about this." Afterwards, I talked to him a little about it, and what I asked, I said, "Weren't you just scared about us doing this?" And he said, "Well, yes, but I can tell you, I was even more scared just about coming to the hospital before reading about it. It was an unknown dread of what it is that's going on. All these people making decisions, people walking in randomly, telling you they're going to do this, telling you they're going to do that." And oddly enough, this was the one thing he understood during his entire hospital stay. He knew what people were doing and why. He knew where the risks were and where they weren't. And he could say, "All right, I'll let her try twice. But then I want you to step in." And she got it on her first try, thank goodness. But there is something to be said that when we're informed and understand what's going on, that we can make good decisions about it and are actually less afraid of what is to come.
Okay, before I give the audience a chance to ask some questions, can we just spend a little bit of time in the middle part of your book, mysteries? As I said earlier, I used to love the medical mysteries of Rocher, but these don't give solutions. You bring up problems, symptoms that are very, very common in medicine: pain, nausea, influencing willpower, right? Blushing. All things that can happen to lots of people would like to have an answer for, that are not part of the medical curriculum. We do not teach our medical students how to deal with these problems. When you do a search, probably in the literature, you find very little in terms of real evidence. Is that because it is difficult, or because it's not a sexy subject to do research on, or because nobody ever bothered to worry about symptoms that were not real diseases? They were dreadful for the patient, but the doctor couldn't do anything about it, so you could just put it aside and forget it. What do you think?
It's true that when you do a search in medicine to go through the medical literature, you can pull it up on the computer very easily, and you do a search on a disease, you find lots to talk about. But if you do a search on what patients actually come in to talk to you about, it hurts here, or I just feel sick, or I'm really tired all the time and worn down and I don't know why. That's what people come to you with. And that's what we have the hardest time dealing with. If they only would come in saying, "I have Fabry's disease," we could go from there. And I think the reason why is that medicine, you're right, is not oriented towards the problems that people come to us with, and don't think about it in terms of the ways people come to us with them. It's also, though, precisely this ground which is the most contentious and most conflict-filled, because this is the grounds in which the physical and the mental become inseparable. We, first of all, don't have a good grasp. Since the time of Descartes, we've been debating about how separate the physical and the mental are, and we still have a language that can't even deal with it. If our architect, who had a pain in the back, and had no X-rays, had every X-ray showing no particular problem with his spine, saw a doctor yet again, they would likely as not tell him, are you faking it? Or would be thinking that in their head, or wondering if the guy's just looking for disability, or wondering if they have just a psychological problem that needs a psychiatrist. The truth is very difficult. The pain system is not a nerve system. It's a system in your brain. It's like a software program. And there are certain things that trigger it to unfold, like you take a knife and you stab somebody in the back, and that will lead that back pain program to run. If you have that patient fall down and fracture their spine, that back pain program will run. But there are certain situations where that program will run even without those conditions. It can run for some people because it's a system that's become haywire. It may be because of just a change in temperature, a light touch to the skin, a change in their mood. And then we don't know what to make of that. We are starting only now to have research unfolding that looks and finds unusual ways of thinking about this. It turns out, for example, that anti-seizure medications are a new class of drugs that may be more helpful for chronic back pains than was ever recognized before. And there are new drugs being developed that really are aiming to change the pain program in the brain rather than focusing on operations for the spine, which have always been dissatisfying and have had very poor outcomes results. The lesson to me heads in more than one direction. One is that we have to come back to thinking about the individuals and the cases again, and the stories, which to me are fun to tell, and I love getting absorbed in them. So, the brain is still obviously a very limited, we've only reached the edges of that frontier. We don't really understand our immune system and autoimmune diseases, problems like multiple sclerosis. We don't understand really how babies are formed and made and the defects that occur unfold. And we're only beginning to grasp how it is our genes predispose us to problems like heart disease and cancer. So there's an enormous amount still to go and to learn from, despite all of the confidence we give you when you walk in the door and say, I know how to take care of that.
Okay, now, up to you. Questions? Go ahead, Eric.
What's your experience about consultations where the new cases in the medicine, and there always needs to be observation to discussion and the ones that are involved in discussion. And there, well, I mean, in the theory, once you really do fast, you know what you're doing, and you see the next patient within 5 minutes again. And at the same time, you see somebody in front of you want to do the best they can for doing. So what's your experience about that?
One of the strange things about learning how to take care of people is that you're constantly doing more, being asked to do more than you think you're capable of doing. Each year as you progress, 6 months ago, I didn't feel like I could handle a gunshot wound to the abdomen. And then this summer came my trauma duty in the United States. In a major hospital, when you've reached your final year of training, that means you take responsibility for overseeing all the care of the trauma victims as they come in, call in the trauma surgeons who will assist you. But a gunshot wound to the belly means that the trauma surgeon's coming in from home, which is at best 15, 20 minutes away, and that you've got somebody who's not going to make it unless you get them through that. And the expectation is, nonetheless, that you're going to be perfect, that you will take care of this situation as it's supposed to go. It's 3 a.m., you've got 5 other patients who've been lined up to see you, you're suddenly called in, you're harried, you're harassed. And yet, and we did have, I remember very well my first, this was actually a stab wound to the abdomen, a gang victim who The stab wound went up from the right part of the abdomen through the liver into the chest and into the heart. And in a way, it was actually a liberating moment, because this is a kid who had no chance of living. If we saved him, we could be heroes, and if we didn't, then no one was going to get mad at us. But I thought I did not know anything about how to deal with that situation, and yet I had been in the abdomen enough times. I had been trying, you've had it hammered into you, you've had the stories of everybody else who tells you about, man, last night I had this case, you wouldn't believe it, and you ask them, how did you do that and the next thing I knew, we were doing everything we needed to do. And within 15 minutes, we had that guy on a cardiac bypass machine, and I'm still flabbergasted we got this kid through it. The attending surgeon arrived 25 minutes later, and there is that pressure that you can easily try to hide the little ways in which maybe things were not done right. But this is someone's life on the line, and one of the lessons you learn is that it is better to be wrong and honest about it than it is to be apparently perfect. And so I explained to him that I thought I had everything under control, but I was not sure, that there were areas that were still bleeding, that I had not inspected the way I had hoped to within 20 minutes of this patient arriving. And that was fine, as long as it's out there. The lesson in medicine, or in surgery that we talk about, is that there are three kinds of errors. There is a judgment error, there's a technical error, and there is a moral error. A technical error is the most forgivable kind of error. It is a slip of the hand. It is a forgotten something. Those are very human, fallible errors. A judgment error is a little more upsetting, but it's still forgivable. A judgment error is when you've seen a patient in a certain situation and taken a decision not to take them to the operating room, to order them some blood, to do something else. And you've made it inappropriately, but those mistakes can be made. You can learn from them and move on. A moral error will get you fired, and I've seen people fired for a moral error. It can be as simple as someone asking you, what was the blood count on this patient? It's something that you have to know. But if you make it up, that you become somebody who can't be trusted. If you ever tell a lie to one of your attendings about what it is that's been going on with a patient or a problem that's appeared, that automatically makes you untrustworthy. And I think that distinction applies in politics as well.
They don't get fired, do they?
Well, sometimes the public does fire them.
Yes, sometimes
we will forgive them a judgment error or a technical error, and I think they sometimes don't understand that we won't forgive them a moral error.
No, that's right.
So that's, I think, my way of thinking about it, how it all occurs.
Other questions? Yes.
Yeah, you spoke about the learning curve, and how do you help them in America? For instance, to postpone contact with patients during the first time of the learning curve by computerized devices or handheld operations. Is it common? Is it more common?
Very uncommon. On the one hand, we do postpone the exposure.
Could you repeat the
Oh, yes.
question, because people in the back haven't heard it?
The question was, in the United States, what is our experience with the learning curve in terms of trying to deal with it by having people work with simulators and computers and so on before actually turning to a patient? In a sense, there's two kinds of learning. There's learning before doing, and there's learning by doing. And in the United States, as in most places, there is a delay in how much learning before doing occurs before the learning by doing occurs. You have to do at least 2 years of classroom studies. You have simulator training with patients and doing even physical exams with models and working with animals to some extent. After about 3 years, though, you then are observing and watching people, and then at a certain point you are thrown into the ring. We don't, I don't think, use simulators and animals especially as much as we could. I think it would give people a great deal more confidence. The difficulty is, of course, to imagine taking a system that already relies heavily on this cheap labor of the trainee and having them be removed from the hospital where they take care of a lot of the paperwork, ordering the medications, writing the prescriptions, making sure patients get from the x-ray room to the back to their hospital room, making sure that their allergies have been properly recorded, that the nurse is given all the medication. That all is the job done by the most junior level people. And if we had the money to take some of those people out and replace them with other helpers, then in the United States I think you'd start to see more time given to putting them in a laboratory, if we could build a laboratory too, the animal lab, or computer simulators, or that kind of thing. We have some role. I'd say in the last 8 years, I've practiced upon 3 goats and used a computer simulator twice, and had lots of times over lunch asking people, how exactly did you do that? And thinking through it in my head and trying to imagine it, practicing in my mind. But that's about it. It would be wise and helpful to be able to do more. At a certain point, though, it never stops. It ends up being that you have to throw them in the ring. The best way I can explain it is that my father, who's been in practice 30 years, pointed out to me that this is not something that occurs at the beginning of training and then ends. The learning curve does not go up and then you are plateaued for the rest of your life and able to have the fruits of that original training. He said every year there is a new technology, something that he has to learn that he's never done before. And at this point, 80% of what he does as a urologist is new to him. 80% are skills that he did not learn as a resident in training with somebody there looking over his shoulder, instead had to learn it on his own. And so when the new laser came out, that was the first laser he ever had to use, how did they teach him? He drove 100 miles to a class in which they had an egg in some water, and he was to practice getting the shell of the egg off while leaving the inside intact. And that was great. He got some dexterity with it. But at a certain point, there was a first patient and a time to do the real thing.
Other questions? Yes. Here and there.
How does the litigious nature of practice in the States affect the practice of medicine for us? You know, the answer is it does affect how we practice medicine, but it doesn't, having had a chance to observe something about how medicine's practiced around the world, it doesn't fundamentally affect practice hugely differently. There is a quantitative difference because we're so aware of the fact that a patient could sue you and our malpractice insurance costs are extremely high. There are, I'd say the thing that you don't have here that we do have there is, for example, in the state of Nevada, the cost of being an emergency room physician is so high that there are emergency rooms that have had to shut down because they couldn't find physicians who could afford to pay the malpractice insurance. That there are areas where obstetricians will not practice because to include those areas would put your malpractice rate so high that you can't practice there. And it's reached that level of absurdity is resulting in some regulations to control lawsuits. But fundamentally, the thing that makes the real difference is whether when an accident has happened, a mistake has been made, whether you can go up to a patient and say, that there has been a complication, that we believe that, as for example happened recently, that we gave the wrong drug to your father, and the reason why was that the handwriting was illegible at the time that the order was given. That is a conversation that will only rarely happen. Physicians are very hesitant to say that, have that conversation here or elsewhere, because it can mean a lawsuit almost anywhere. And a lawsuit is on the one hand, a means for genuinely compensating people for harm that should not have occurred. But it's also, in our day and age, a way that physicians' licenses are taken away. They're called and questioned as negligent physicians. It's a kind of punishment, and it can lead physicians to make what I think is a bad moral decision, which is not to tell patients about the truth of an accident that happens. We are, in fact, committed as a profession to have to tell people about what has happened to them. And despite the legal system, I'd say the norm is that we tell patients exactly what happens, even though when it comes to using the word mistake, we may not use it. We might say a complication has occurred. We use the passive tense. We say that a drug was given that may have been the wrong drug, and we are now giving an antidote. But the truth cannot be covered up, and yet it is the central problem of a legal system like that.
Okay. There's a question over there.
Well, I want to know how many hours does a resident work in a week in America?
In America, they're long hours. The average in our program, and we measure this because we're entering new regulations next year, was 110 hours a week. There are 168 hours in a week. That meant about 58 hours in which you got to go home. There are weeks where it would be 130 hours. There are other weeks where it's 60 or 70. It's a very intense experience. Part of the ethic of surgery in particular is that, and part of what I love about surgery is that we are available to take care of sick people. And sick people don't come scheduled. You have to be available 2 o'clock in the morning, 2 o'clock in the afternoon. But it is also true that fatigue can result in errors and contribute to mistakes. And trying to balance the reality that you need to provide time off for just to regain human composure, to get some rest, to take some perspective on what you're doing, is necessary, but needs to be balanced against the other side of the coin, which is, well, let me put it this way. We did a study in our hospital where we created a night system, a night team, where a fresh team would come in from 12 midnight to 6 a.m. and give a break. The first thing that happened was, and we measured the errors. The errors went up instead of going down. It turned out that having someone who was really tired but knew you very well could be safer than having a fresh team who didn't know you at all, didn't know that you shouldn't ever get a certain drug because it causes problems for you, or why you had an x-ray 8 hours before. We then put in a computer system that had each physician sign out all the information about a patient onto a computer so that they could get the information for the fresh team. And that brought the error rate back to about the same, brought it back down. And so people thought that was a victory. We then went around and asked patients what they thought about the system, and they didn't like it. They now were being taken care of instead of by one person who knew them, by shifts of different teams, and they never were quite clear who their doctor was. And that's struggle with how complex this machine is, and making medicine seem accessible and human and kind. At the same time, you appropriately deal with getting people less fatigued, bringing in the computers that really can help, making the technology accessible, is the very hard business of modern medicine now.
One last question.
I was wondering, you talked a little bit about the changing role of medicine and also the changing role of the patient. How do you foresee a future where patients can be more informed and demanding treatment as opposed to offering themselves up to a doctor?
Yeah, well, we talked about this a little bit. Oh, yes. The question is that the changing world is one in which patients are becoming better informed, and what happens as patients become so well informed that they can dictate their own care, come to you asking that certain treatment be provided. And the answer is some of that is bound to be good. Having people take charge of their own care has enormous potential for improving everybody's health. The difficulty is that it's also true that while doctors are human and can make mistakes, patients are human and can make mistakes too. And one of the things that troubles me is this language we're adopting as we enter a new era in medicine, which is a business language. We talk about the consumer instead of the patient, and the doctor as the provider. The trouble is that what patients and people need in the course of their lives when it comes to being able to use medicine in the best way possible is someone competent and someone kind to help them through it. The competence we've talked a great deal about, but the kindness is a little bit hard to follow. Part of kindness means most of the time simply doing what people ask for, once, as long as it seems to be the thing that will help them achieve what they want to achieve in their lives. But sometimes people come to you and you have to push back, and that's not what providers do to consumers. But if you're a doctor, there is a role for that sometimes. It means that the person who comes to you who still smokes, says they have no intention of quitting smoking, can sometimes need a lecture from you, even a paternalistic seeming lecture about how their miseries, their pain in their leg that is afflicting them, the heart problems that they keep coming to you with, would actually be better and improve. It also means that sometimes you will see, that we'll all see, people, relatives, and have relatives of ours, if you're a patient, patients of yours, if you're a doctor, we'll see them make bad decisions and then have to sort out what to do about that. Many times, the best thing, the kindest thing, is to let people make bad decisions and then live with their consequences. But sometimes those decisions are so out of tune with the direction that would help that they want for their own lives, that you sometimes have to push back, argue with them, cajole them, get angry, do things that I've had to do with sometimes patients. And that is not the provider-consumer relationship. I try to think what the metaphor is. Sometimes I think it's dancing, where two people are dancing and it takes two to tango, but one person is sometimes trying to lead the way. Although it doesn't always hold up. Another is the counselor, the priest and parishioner kind of role, but that seems almost too hierarchical for the kind of nature of medicine that's evolving. But it clearly is not simply a situation where a patient sees an ad, comes in, says, this is the medicine I want, and the doctor should say yes, which is in fact what doctors in many parts of the world are doing.
Okay, I think that's the perfect ending to what to me has been a very exciting evening. I don't get to do the closing remarks. I now hand back to Saibal Noorda to do so, but thank you very much for having this conversation.
Thank you.
Thank you very much indeed on behalf of the John Adams Institute and on behalf of the University of Amsterdam. It was our pleasure to have you in our university today. You have immensely enriched our vocabulary, the art of being a patient, and of course the Schuldeis miracle of hernia operation. That will be part of our family conversations maybe in the future. No perfection without practice, and managing uncertainty. And there was always a sort of connection between your stories. At one point I thought that the bullet you couldn't find in the first story would suddenly turn up in the last story in another patient. But the nicest thing about your presentation and about your book is probably that you are presenting to us the kind of person we want our doctors to be human. And you can have that sign on the wall, to err is human, but you are not particularly wanting to show this to us by erring. It is so. It has been a pleasure to have you here. Thank you very much, Dr. Gawande, and I'm confident that many of us will continue this pleasure by reading your book. Thanks also to Professor Gunning, who was very ably sharing this meeting, and whom we thank to an extra amount of insight into Dr. Gawande's presentation and thinking. And ladies and gentlemen, of course, most thanks to you. I mean, if you had not shown up, this meeting wouldn't have taken place. If you had stayed at home reading the book and not come here, we wouldn't have had this tonight. So you are the deciding factor. And you can be that kind of an audience again next week. Next week we have a presentation of youngish American writer, Jeffrey Eugenides. I think you pronounce it in American. In Greek it will be completely different. His first book that made him world famous was The Virgin Suicides a couple of years ago, and he has written a new one, and he's reading from that, and is there to be answer questions and so on and so on. So the 14th of November, next Thursday. And then the next week, I mean, we are like developing into a weekly program. On November 21st, Peter Gay, the eminent historian of 19th century history, for instance, and Freud and what have you. And so we'll have a chance of hearing him and discussing with him on November 21st. You can sign up for these evenings downstairs tonight already. There you can also pick up a brochure that enables you to write your name down and become a donor to this non-profit organization that's organizing these beautiful American lectures every now and then. It was a pleasure to have you here. I trust that you will leave your questionnaires filled out with us, and thanks for coming, and enjoy the rest of your evening.